But what I wanted to do is hear the voice of survivors first.
Well, I was 16 and it was a nice warm day, normal day. There was no idea it was going to happen. The room was already prepared for our cutting, because in Eritrean we call it the cutting. So in that room, as I laid on the floor, another friend of my mom, who's quite big, she sat on my chest. She almost seemed to keep me quiet from screaming because I was fighting and what's going on? And at the same time, people are pulling my clothing and pulling my knickers. She came in with the knives and little blades in her hand, and a cloth was put in my mouth so I couldn't scream.
And my legs were spread apart, and I felt a sharp cut in between my legs. And after that, I screamed. I screamed so loud. As I speak to you, I can still feel the blade going through my skin.
Female genital mutilation constitutes all procedures that involve partial or complete removal of the external organs of the female genitalia for non-medical reasons. And in 99% of cases, the procedure is done without any anesthetic. Instruments could be broken glass, razor blade, scissors.
The time they do for me the FGM, it was my father's mom, and I was 5 to 6 years. I was very young, and when my mom coming and find out, she was very angry and cried.
That day we were left by ourselves in that room for the next 4 days. I'm just crying. No one cleaned us up. We were still bleeding. My sore for me was just getting worse, but I couldn't tell anybody.
So I would love to show you all of it, but I don't have time. I'm going to fly through what FGM is because we want to talk about the barriers to accessing help. But I've been around since 1995 when health visitors used to visit and midwives visited every day for a month. And you're absolutely right, resources are being cut all the time. I was told the other day there's a threat to my clinic. So, we have to worry about gender inequality, but also resources all the time within the NHS anyway. I want to just go directly into the different types of FGM because it is important to sort of understand that any type of FGM can have lots of psychological consequences for women. We talk about type 1 in particular because we know that it may be becoming more common and it may be done to younger girls because obviously there's going to be more difficult to discover if a less severe type is done. But actually even type 1 can result in pain for the rest of your life, bleeding to death, injury to adjacent organs, spread of HIV infection, hepatitis. So the consequences of type 1 for some women are just as severe as any other type. So talking about the different types, type 2 where some or part of the clitoris may have been removed as well as the labia minor. And then you have type 3, which some women call pharaonic circumcision, where the labia have been removed and then the edges have been stitched together, or sometimes they just fuse together. And then type 4 is any other procedure that's been done to the female genitals, sometimes pulling and stretching, but other forms of sexual violence have sometimes been done to women's genitals as well. Deinfibulation is the opening procedure that we do to try and open the scar tissue, but it doesn't actually put back what's been taken away. And as I'm sure you're aware, FGM is done for many different complex reasons, but in the end of the day, it's to get women to behave better. Why should they enjoy sexual pleasure like men do, after all? These sort of ideas are perpetuated, but there's lots and lots of myths around FGM. So, for example, saying a woman isn't clean, and so she can't eat with the family until she's cut, she'll never get pregnant, her children will die during childbirth. Religion is another justification that's sometimes used. So there's lots and lots of different myths that are used to justify the practice. It's done very often by a traditional lady or even sometimes a man, but actually in some parts of the world it's now been very medicalised. So for example in Egypt, over 90% of the time it's been done by a doctor. In Sudan very often it's been done by midwives. And unfortunately there's an economic part of that as a component to that as well, which is why it becomes perpetuated. It can happen to girls when they're babies. So, for example, a lot of the Eritrean women we see, they're within a few weeks. And other women, I've met women who were in their early 20s when they were cut. These are some of the instruments that involve. So thorns, razor blades might be used to cut girls. And FGM, we know, is now all over the world. So the white bits and the grey bits doesn't mean that it doesn't happen there. It just may mean that we don't have the data. And they say that there may be another couple of million women in Russia, for example, that have been cut from within the Kurdish community. So we're constantly discovering more cases of FGM. And in fact, the World Health Organization actually upped their figures. So they used to say 120 million women and girls have been cut. And a few years ago, they updated that to say 200 million. So the reason I put in this slide is just to show you how within a country, maybe one village they practice FGM and the next door village maybe they don't practice FGM. So this is not uniform across the whole country, but unfortunately there are parts of the world where more severe types of FGM are more common and it's more prevalent obviously in some countries than in other countries. This is just to show you how language is involved as well. Words like purity and virgin are sometimes associated with words that are used for cutting girls as well. And that's how it kind of can become very embedded within culture. Some stats from the UK. This is we have this mandatory reporting of data now. So when women are identified who've had FGM within NHS services, we're meant to be sending that information to NHS Digital. And as you can see, 15,390 patients were identified with FGM within the NHS. Now, there was a bit of a media hysterical outburst after these figures came out because people thought, these girls have just been cut in our country. And of course, it's not true. Luckily, 99.9% of the cases we see are historic cases. That doesn't mean that girls who have been born in this country haven't been cut here, because I've come across some, not that many luckily, and sometimes girls that have been born here have been taken abroad and cut. So there are those cases, but there certainly aren't thousands of them, thankfully. So this was a estimation looking at the numbers of immigrants of women in this country to try and estimate the numbers of women and girls at risk in the UK. And apparently the NHS digital data sort of verifies more or less these figures, if anything, there are actually more. And this is just a graph to look at in London, so you can see areas of different prevalence. And this data comes from the NHS trusts that have been sending this data to NHS Digital. So you can see, for example, I work at Imperial, so we're based in sort of Shepherd's Bush, and you can see Brent, Ealing, Westminster, Hammersmith and Fulham is areas of high prevalence for FGM. And as you can see, just in general in the UK, just over 50% are in London, but obviously there are women all over the UK that have had FGM. These are some of the short and long-term consequences. So you can imagine some of these. From a small child wriggling around, obviously can cause lots of health consequences. Similarly, in the long term, I had a lady come to my clinic last Friday. She's been living in the UK for 36 years. And she said she's had some urine infections. I said, oh, how many times have you had antibiotics for your urine infections? She said, hundreds. And the lining of my stomach is ruined because of all the antibiotics I've had. And I said, so we were looking at some line drawings, and I said, what type do you think you've got? And explaining the different types. And she said, well, I think I've got, type 1, I think, that one. I think they cut my clitoris. And when I had a look, she's actually got type 3. So her introitus is about 2 centimetres by 1 centimetre. That's where she's passing urine and menstrual blood and having sex. She's been having painful sex for many, many years. She's been to the GP many, many times. She's had cervical smears using the smallest, can't think of the word of what you do them with, gone blank. But she's had lots of cervical smears. Nobody has ever said to her, you've got type 3 FGM. And so it just shows how that sort of information women don't necessarily know about. Obstetrically, obviously, it can cause problems, particularly type 3, but any type of FGM. Women are more likely to suffer perineal tears because of the scarring of the introitus, therefore they're more likely for postpartum hemorrhage and a longer maternal stay. Luckily, probably in the UK, there isn't such a danger to babies because we'll run women down the corridor and do a C-section. But certainly we know that there's higher risk of obstetric problems with FGM. And the psychological consequences can be very extreme as well. Not all women, some women are fine, but we see some women that are very distressed. Sometimes they might have flashbacks, not just during labour, but also maybe just when they're having sex. And sometimes just sitting on the bus, something might remind them of when they were cut. So you can imagine that sometimes mental health is a real issue for some of the ladies we see. In terms of the law, sorry, but I have to mention it when I'm here. We know that obviously the Circumcision Act in 1985 and more recently the Serious Crime Act has meant there have been a lot of changes. Some of them are good. Some of them, I worry, really mean that women will be find it more difficult to access services and may become more alienated from accessing help. And this is just a slide about the recent successful prosecution, which is the first ever one in the UK. So 2019, note that the first law was 1985, so it has taken a long time. So finally, I get to the point of my, my presentation, barriers. Certainly there's a huge taboo around talking about FGM, and women often will say they feel ashamed about it. There's a stigma. For some women, most definitely, you hear horror stories of women, for example, during labour, where midwives and doctors coming into the room and going, oh my God, have you seen this? Imagine how the woman feels if that happens to her. There's a lot of cultural pressure as well. Women sometimes don't access our services until they're about to get married or they've just got married because it's quite taboo to even talk about FGM to anyone, but that might be the window of opportunity when they're allowed to talk about it. Many women that I see are asylum seekers or refugees. They may be economically disadvantaged. Sometimes they speak very little English, and they may not know that there are specialist services out there. And of course, the politics and the policies mean that some women are very frightened. They're frightened of social services taking their children away. They're frightened they might go to prison. A woman said to me the other day, how much does it cost to come and get a reversal in your clinic? I said, it's free. You know, this is the NHS. So women don't know sometimes about those things as well. There may be male GPs, obviously they're the gatekeepers. And a lot of women, they think their problems are normal. They think FGM is normal. They've had it for all of their life. We have problems with very few services in low prevalence areas. Few healthcare professionals who actually know how to diagnose the different types. There aren't the mental health specialists we need. Women want access to clitoral reconstruction. So you can see these are lots and lots of the different barriers that there are. Another thing is actually from professionals ourselves. Sometimes we're frightened to ask the question. We don't know enough about FGM. We may have very restricted time to actually talk to women about FGM. Funding is an issue. And I think people sometimes see the FGM practicing community as if it's one homogenous group, and of course it isn't. There are many, many different diverse cultures and places where FGM is being practiced. We don't have good guidelines for FGM. And in real terms, this can mean women sometimes can't access, for example, birth centres. They may not access antenatal classes. They may book late for maternity. They may not turn up to appointments. And actually, a lot of the women we see, they are quite vulnerable, sometimes not only to mental health issues, but domestic violence, forced early marriage, trafficking, witchcraft, those sorts of things. So women are at higher risk of, as I've already said, perineal tears, PPH, longer maternal stay. And the Embrace report you all know about from 2018 found black women are 5 times and Asian women 2 times more likely to die as a result of complications in pregnancy than white women. Well, unfortunately for FGM, of course, they fall into this category as well, and they've got a double stigma, haven't they, really? So I want to talk very quickly about my clinic. I know I've only got 1 minute. We call it the Sunflower Clinic. We don't call them African Well Woman Clinics anymore because FGM doesn't only happen in Africa. We have a service for pregnant and non-pregnant women. The woman is at the centre of the care, so we have midwife, counsellor and health advocates. We're very lucky having this very special model of care. We have to go outside of the NHS to find funding to perpetuate it. We see about 600 pregnant women a year and about 100 non-pregnant women in our clinics. And this is some of the members of the team that I work with. We do see the majority are Somali, but we also see a lot of Eritrean, Sudanese, and basically we see women from all over though. And as you can see here, different types of FGM, so a lot of women with a history of type 3 or an intact type 3 FGM. 43% of our women, so I did a survey of 100 women, it was the first time they'd ever talked about FGM with a professional. 12% of the women spoke no English at all. So these are the kind of things that make, obviously, it very, very difficult for women to access care. And thankfully, having health advocates does make it a lot better. What we did was we introduced a clinic where women could self-refer. There's no geographical boundaries. We see them within 2 weeks. We have our health advocates now counsellors. Our fantastic leaflets that have been translated by some of your Leigh Day ladies. Thank you very, very much for your help. We're cheap midwives, actually, so a doctor running the service would be a lot more expensive. But it's very much involving the community as joint partners in the work we're doing in shaping and delivering our services is very, very important to us. So this is just talking about the numbers of women that we see in our service for non-pregnant women. The reason women come, because they're about to get married, but often it's a combination of factors. So maybe they're about to get married, they can't have sex, or sex is extremely painful. It might take about 10 minutes to pass urine. The urine might dribble out, and they feel like they can't empty their bladder, so they have to keep going backwards and forwards. They have very painful periods. They're only passing blood clots, and recurrent urinary tract infections and infertility are obviously issues as well. Women come from all ages to my clinic. The lady I was talking about was in her early 60s, and we get younger women as well. Women travel a long way to come and see us. You can see this is a breakdown of all the different boroughs in London where women have accessed our clinic from. I think it's probably all of them, actually. But it shows, again, that for women, sometimes it's quite taboo accessing a sexual health service that's nearby. Women don't want to be seen going into a clinic nearby. So that's another reason why women might travel a long way to come and see us. And we see women as well from outside of London. The ladies from Germany and Norway would probably have been living in the UK and then married, moved abroad, and then came back to be defibrillated because they didn't know how to access services locally as well. We used to have an advert on Somali TV, and a lot of women heard about our service through our Somali TV advert. But also more nowadays the internet, actually. I get women emailing me saying, I've never talked about FGM before, please can you help me? I don't know where to go. We see women, again, all ages from when they've actually been circumcised, and obviously there's a proportion of women that don't know and don't remember. And I just want to finish with a lady. We had an Eritrean lady come to our clinic, and she said she'd come to the UK when she was 3 years old, and she was brought up in the care system here. And when she was 18, she had a urine infection. She went to her GP, and the GP said to her, oh, you've got FGM. And she said she was like, what? She'd never heard of it. She'd vaguely heard of it, but she never had any idea it happened to her. And she said that she came to see us, but she said she'd spent 4 hours Googling, and she said no one had ever told her before that you've got 2 separate holes, one for passing urine and one for passing menstrual blood and having sex. And she said, I got an A star in GCSE biology, but I never knew that. How is that possible? So this is some of the problems that women have before they come and see us. This is some of the perineal trauma referrals. You can see second-degree muscle tears, cysts, fistulas, incontinence. So what we do is we diagnose the type of FGM, we do a mental health assessment, we discuss the health consequences, we talk about their human rights and their right to enjoy sexual intercourse. We also explain to the women the difference between male circumcision and FGM, because we want women to understand that actually, number one, the intention is different. You know, FGM is about stopping women enjoy having sex. That's not what male circumcision is about, as far as I'm aware. But also, the physical consequence, it would be as if you cut the penis in half. And women don't seem to know that. They think, isn't it the same thing? So it's really important that we're educating women the difference between the two. Otherwise, I think that there's the possibility that FGM will continue. So we do talk to women about their human rights to bodily integrity and to enjoy sexual pleasure. We carry out safeguarding assessment, and we offer defibrillation for women with type 3. Thank you very much for listening.